Okay. Okay, so I'm gonna start. We're live now. Good morning, everyone. Welcome to TeleShadowing. Please be free to ask questions in the question box as we go along and they'll be addressed. We are currently live. I'm honored to introduce our mentor for today, Dr. Ahmed. Dr. Ahmed serves as an assistant professor of radiology and nuclear medicine at the R. Adam Colley Shock Trauma Center at the University of Maryland Medical Center in Baltimore, Maryland. Dr. Ahmed attended St. George's University School of Medicine and completed his preliminary year at the Richmond University Medical Center with a focus on medicine. Dr. Ahmed also completed his residency in New Jersey with a focus in radiology. Following residency, Dr. Ahmed then completed a fellowship in musculoskeletal imaging at the University of Maryland.
My apologies. It somehow keep disconnecting me.
Okay, you're fine.
Sorry about that. Hopefully it should work now.
Yeah, you're good now. We're able to see the screen now.
Okay.
Okay. So currently, Dr. Ahmed has served as an emergency and trauma attending at the Dartmouth-Hitchcock Medical Center for 2 years at the University of Maryland for more. And now it is my honor to request Dr. Ahmed to begin today's session. Thank you.
Hello, everyone. My name is Ahmed.
So Dr. Ahmed, you're muted.
I'm sorry about that. Hello, everyone. My name is Ahmed. I'm one of the assistant professors at University of Maryland Shock Trauma Center. I currently work as a trauma attending. I'll discuss how the whole journey started, and we'll just go from there. Okay. So I basically started off. I was born in Pakistan, Lahore. This is where I actually did my schooling from. Went to this school system called the City School. It's one of the schools in the city of Lahore in Pakistan. And I went there. I did my O levels and A levels. If you don't know, that's a British system. Even though I'm in Pakistan, it's called GCE, by the way. O means ordinary level, A means advanced level. It's basically equivalent of high school. But the A levels basically is like 13 years of schooling. So then I came over here. I went to Brooklyn College. This is my college. I majored in chemistry and bio, have a bunch of minors in philosophy, math, and I think CIS. Then I went to medical school. I did my prelim year in Staten Island, New York. There's a hospital called Richmond University Medical Center. There are only 2 hospitals in Staten Island. This is one of them. Then I did my residency, and residency was in radiology in New Jersey, St. Barnabas Medical Center. Then I did my fellowship. The fellowship was technically in musculoskeletal imaging, but I'll tell you later, it's very similar to musculoskeletal imaging, / trauma. It's pretty much the same thing. Not exactly the same thing, but very similar. Then, I started practicing as a trauma and ER radiologist at Dartmouth-Hitchcock Medical Center for almost 2 years. I didn't do musculoskeletal imaging, but I'll discuss that later. Then I came back to Maryland to start working as a trauma attending. Here, they have a distinction between trauma and emergency imaging. Trauma is completely separate. Emergency imaging is separate. Okay, so why did I choose medicine? Basically, the reason for choosing medicine is like I wanted to help people. And, whenever I was young, people will ask me, what do I want to do? I'll just tell them I just want to become a doctor. So, there was nothing exciting about that. Uh, but I had this innate thing where I wanted to help people. I wanted to make a real change in the world, like, typical things. And, I put control and responsibility because once you are given in charge of a patient, you have to take care of the patient, like, make sure everything is going fine. So I wanted to have, I wanted to have this sort of control, not necessarily in a bad way, but, in a good way. So, then, it's a altruistic thing to do, but, the caring for the people is essentially the same thing. Okay, then why did I choose radiology? Basically, there are a lot of fields I could have gone into. In fact, when I did my prelim year in Richmond University Medical Center, I actually really loved medicine, and I did it in internal medicine, and my program director really liked me. Actually, he really encouraged me to stay. So basically, what it means is that I could have done internal medicine and just 2 more years and I will be a medicine doctor. So he actually really liked me. But I chose to go with my passion, which was radiology. Why radiology? So it's basically like a detective work, okay? One thing. And then the other thing is you're not helping regular people. You're actually helping other physicians. So which is you know I really liked. So you still have patient contact, don't get me wrong. It's just that the patient contact is minimal, mild, I'll say. Uh, Only when you have to do the procedures, let's say you are doing joint injections, you're doing joint aspirations, you're doing, you know, uh, when I say joint injection, basically what we're doing is we're injecting medicine. Sometimes we inject dye, which we call contrast. So see, in certain studies, it help us better delineate, certain things. Let's say, give the contrast. If you want to look for meniscal tears in the, in the shoulder or in the knee, then basically you inject contrast and see better delineate the anatomy of the knee joint. Then, it's I like challenging stuff actually. I like things which challenge me uh, because then I think uh, you know it's more exciting. Uh, when it's not challenging, it's very easy to get uh, bored. When it's challenging, you do struggle. Uh, you know, a little bit. You do struggle, but the thing is, the end is very rewarding. So I like that. I like that feeling. Uh, and the thing is, radiology is not for everyone. And there are not that many radiologists, believe it or not. I don't know the exact numbers, but I can tell you one thing: for every medicine doctor out there, like a general practitioner or even cardiologist, there are, let's say, for every 20, maybe I will say like maybe 30. I don't have exact numbers to be honest. I would say for every 30, there's only one radiologist. So, that's a pretty small number. So it's a pretty small community. Almost like, everyone sort of knows everyone. At least if you're in the same area, I would say. Or they somehow know, hey, you're connected to someone. Okay. The other thing is you have a lot of variety in radiology. Uh, you know, and like I said, uh, it's very a lot of variety from procedures to all the way, you know, completely in front of the computer and reading everything. So, if you do, let's say for procedures, you could do IR, which is like purely procedure based. And depending on what kind of work you do, you can basically just do purely procedure based, practice. Um, the One of the biggest reasons I chose radiology was actually uh, lifestyle. So, um, I can, if I decide to do purely reading, then I can work from home. You can essentially work anywhere from the world. It's just that you have some laws over here that prevent you from doing that. So, you have to be in 50 US states to read anything, to sign final report. You can actually prelim stuff, uh, you know, while sitting outside of the US, but you have to be still licensed in the US to be able to do that. So that is actually pretty exciting. Then basically, it's like I said, it's a detective work. So, but there are what did I have over here? 4,096 images of gray to 65,000. That is crazy. Which any X-rays or CT, uh, they can actually show you that depending on your screen. A human eye, on the other hand, can differentiate 900 shades of gray. That is crazy. You would think, they're only like, hey, maybe 10, 12 shades of gray, but you can actually differentiate between 900 shades of gray. And this is actually what radiology is. Okay, one second. Okay. Then you're gonna ask me, why did I choose trauma/emergency radiology? Uh, it's actually even more, unique in a way that where I work, uh, I I don't want to say it, but I think this is the biggest shock trauma center in the whole country, and the only thing I can think of it, which comes close to it, is a smaller shock trauma center, which is in University of Washington. But we have within our radiologist group, which has like quite a few doctors, I believe, like more than 60, 50, something like that. Among them, we have a group of 12 people, I believe, and what we read is just bonkers, because we read way more crazy stuff than even regular radiologists read on a daily basis. Because we read stab wounds, gunshot wounds, uh, like very, very messed up studies, which other radiologists do not read routinely. Like they would read it, but I would say like maybe one study every 2 weeks. Here, all my studies are like that, pretty much everything. Okay, so it's very unique. Uh, the thing about trauma radiology is that it keeps you on your toes. You know, it's very intense. Uh, so I actually like it. It's challenging, but I like it. And then there's this is true for all radiology. It basically there's always something to learn. You would not see a radiologist who would say, "Oh, okay, I have mastered everything." So you could be like a old school 70-year-old radiologist with 50 years experience, and you will still have a lot of things to learn. It never ends, you know. I think that's true for whole medicine, but because you have research, you have a lot of things coming up, uh, which you were not there when you started. But radiology is even more than that. Is that you're never. I know this might come as a negative potentially, but you are never master of anything. You're always learning something. But this is the fun part. The learning experience is very rewarding. And yeah. And the other thing is that in a trauma radiology, you work very closely with trauma surgeons. If you're working in emergency radiology, then you work kind of close to ER docs. But here in trauma, we work very closely with the trauma surgeons. So, for example, if a patient comes in, he's very unstable. They would not ask my opinion. They will just take the patient directly to the OR, operating theater. On the other hand, if the patient is relatively stable, patient would get something called Shan scan that we get basically like a pan scan, the whole body. Then they will wait for my read and then act on it. Then there's a third possibility is that sometimes they cannot decide if the patient is really stable or unstable because patient is right in the middle. So then what they do is they sometimes ask me to come to the CT scanner and just to make sure the patient there isn't a major injury that requires them to go to the OR right away. A major injury in that case would be something like aortic injury or the stab wound, like like a severe stab wound or head injury that requires them to go there emergently, or sometimes large hematoma which is actively bleeding. If I see that, I can actually see that on a regular computer screen. I don't need my fancy 3 to 5 megapixel monitors. I can see that on a regular CT technologist screen. So I just tell them, hey, this is what I think it is. They usually take the patient to the OR. Then the other reason is that as a emergency radiologist, I can I can work through teleradiology. I don't have to be there. But as per Maryland laws, if you are a trauma radiologist, a radiologist attending has to be present over there. But when I work purely as an emergency radiologist, I sometimes do moonlighting, then I can work from home. So which is pretty good. This is how my schedule is like. If I do basically it's 3 days overnight from 11 p.m. to 7 a.m. Then I have 7 days off. Then I have 4 days as an overnight from 11 to 7 a.m. Then I have 7 days off. So basically it comes out to be 7 off, 7 on, 14 off, 7 on, 14 off, 7 on, 14 off. And I could work uh, additional moonlighting shifts if I want to. It might sound pretty good lifestyle, but it's not as good as it looks like, because when you are coming from overnight, which I actually love to do, like I like to do overnight. It takes you at least 1 week to get back to normal. I would say even 8 days just to get your bearings correctly afterwards. After I finish my 7 day or in this case 7 day stint. So like 2 years ago, they decided, actually a year and a half ago, they decided that my actually section chief suggested, why don't we try this? it works really well. And so we basically split the week into half because when you're working 7 days overnight, it can get very tiring on fifth and sixth days because it is very, very intense. Um, and that in like, and I can explain you, like, the intensity level is that I cannot be on autopilot because if I'm on autopilot, just like regular ED physicians or even internal medicine doctors, they can be on autopilot. They're doing the rounds, and they're like, okay, these are the things I have to do. On the other hand, if I'm on autopilot, then I will miss stuff uh, because every patient is so different that you cannot be on autopilot. It's very, very difficult. So you have to be on your toes all the time. And this is the reason it can get tiring. Where I was previously at Dartmouth, Hitchcock, so my shifts were 11 hours. So which was kind of a lot. But the intensity wasn't as high as over here. So uh, I read more stuff in 8 hours than I was reading 11 hours over there. So I would say at least double. So yeah, that's why. So one of the reasons about one of the good things about radiology is that, like I said initially, it's very there's a lot of variety. So I can be reading something like that. So this is the just the AP pelvis radiograph, and you would think that looks pretty simple, right? But it's not. There are, if I start labeling stuff, you'll be shocked. This whole page is gonna get filled. There are so many things. I can read from this to this. This is the MRI of the foot. There's a osteomyelitis over here. Then I can read this. This is the foot MRI to pelvic MRI. There are fractures over here. Then I can read this thing. This is the C-spine MRI. And, there are a lot of findings over here. Or I can read the MRI of the brain, or CT of the brain. This is completely normal CT. There's something over here. Or I can read the CT of the abdomen, which is a workhorse. My workhorse, because we routinely do way more CTs overnight than we do MRIs over here. Or I can basically be doing ultrasound. This is the ultrasound. Or, if I were nuclear medicine doc, then I would be reading this. This is a nuclear medical scan, or this is the heart scan. Like, it's called a PET scan for the heart. I believe it's Italian scan. Or I could be reading the mammography, or I could be reading, this thyroid uptake scan. There are a lot of things. Again, I could be reading the ultrasound, or I could be reading, again, ultrasound as a baby. As a second trimester ultrasound. So like I said, there's a lot of variety. Radiology in general and trauma radiology is a very like intense. There's a lot of variety in that too. Then, uh, you know, uh, I have a few questions. So this is the not a question, just like a teaching case, essentially. For example, this is a wrist radiograph. Uh, these are carpal bones, the proximal row, distal row, scaphoid, lunate, triquetrium. This is the lunate, scaphoid is overlying it. And there's a finding in this radiograph. It's very kind of difficult to see, but there is a soft tissue swelling over here, soft tissue swelling over here, and you see this tiniest thing that's called a tricutal fracture. So this is the tricutal fracture, and it's called poopy duck sign. Yeah, believe it or not, we radiologists have a very unique sense of humor. They can't come up with better names, believe it or not. Then there's another foot radiograph now, and you know, there's a soft tissue swelling over here, a little bit soft tissue swelling over here. There are lines going over here. Some of them could be normal, some of them could not be normal, or in this case, it's a fracture. So, this is a fracture. This is a normal part of growing. It's called apophysis. So, there are different kinds of fractures. If it happens over here, it's called stress fracture. If it happens over here, it's called Jones fracture. If it happens over here, it's called, avulsion fracture. And, Jones fracture, which happens over here, it tends to have a very bad, it heals very badly, or more correctly, it has only, if I'm not incorrect, I think it has only 50% chance of healing properly. So then you have to put a K-pin in. Essentially, what I'm trying to say is that you have to do surgery. Otherwise it doesn't heal. It doesn't heal properly. So you can imagine, these could be very tricky. When you have the avulsion type fracture versus Jones fracture. Okay. Right. So it was pretty short. I like to keep things simple. If you have any questions, and I'll be happy to answer. I don't think I can hear you.
Oh, can you hear me now?
Yes, I can hear you now.
Okay. Thank you for your mentorship and teaching, Dr. Ahmed. We'll now begin our Q&A session. So we got a question from our YouTube live. And that question says, when you're working remotely, does the hospital provide monitors and resources for you to use?
Yeah, it's a pretty tricky thing. Most places will provide you screens. Actually, my hospital does that too. It's just that they gave me a regular screens. Just remember, I'm not saying anything bad about the University of Maryland Medical Center, but it's a semi-government hospital. So what I did was I can read CTs and MRIs on that, or even ultrasound. I cannot read radiographs. And here, you would think, hey, radiographs are simple, but no, they are not. They are a lot more tricky. Because CT has a lot of resolution, and MRI has a lot of resolution, ultrasound has a lot of resolution. Radiographs, on the other hand, they don't have that much resolution. They have a lot more resolution that requires you to have a 3-megapixel monitor minimum. So coming back to your question, these monitors are pretty expensive. Even the one that the hospital provided, these are essentially the regular monitors, which you could say like a gaming monitors if you play video games. You can read a lot of stuff on that. So to answer your question now, I basically bought these monitors myself, but these are mine. So but they're not that expensive. Like actually they are. But yes, generally the workstation is provided by the hospitals or wherever you work. This is the norm everywhere. But in my case, I bought 2 extra monitors myself, which just helps me, But yeah, they do provide you with the monitors.
For sure. Another question we got from the Zoom. How would you mentioned you have an intense lifestyle with your specialty. So how would you maintain a healthy lifestyle with this, specifically on the more intensive days?
Yeah, that's a good question. It's not easy, I will say, because you are sitting in front of the computer sometimes in my last job, I was sitting in front of the computer for 12 hours. And there were times, at least over here, it's very common, where I have to make time to go to restroom. So, it's that crazy. But not every day is like that. Uh, like I say, it's not easy. Definitely. But so let's say, what I try to do is, so I basically use this thing. It's I don't know. I basically have a timer on. I actually got it from one of my other colleagues at Dartmouth. So, the timer would be for 1 hour, for 50 minutes. For 50 minutes, I'll sit, and for next 5 minutes, I'll take a break. I'll just stand up, stretch, walk around, and come back. I have to do that, otherwise, I had the tendency to get muscular spasms, like spasms in the neck. Ever since I started doing that, my back pain and the neck pain went away. But yes, it's not easy to maintain a healthy lifestyle by that. But if you maintain, if you keep stretching, it's helpful, you know. Then the other thing we do is that, let's say at night, it's very easy to fall asleep, especially around like 4 to 4:30. That's like a bad time for me. So what I do is, uh, 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 you know, uh, I basically always have a coffee cup, which is my, you, you need a lot of caffeine for that. Uh, the other thing is that we have this ergonomic workstations. So the monitors, they could be positioned downwards, upwards. Your your desk could rise upwards, downward. These are ergonomic stations. Your monitor screen can go up and down. So it's basically, this is designed so you do not get uh, 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 you know uh, this back pain or muscular pain, but not everyone uses that, which I think they should. But yeah, it's not easy to maintain a healthy lifestyle. If you walk around, I do a lot of exercise, so go to gym, so that helps. And then eating healthy is very important too. So yeah, it's not easy.
Mhm.
Yeah.
So you showed a lot of different X-ray examples and cases. How long does it take to learn how to read these different X-rays and CT scans?
Okay, so let me tell you, it can take you your whole life, and you will still
Wow.
not feel comfortable. I don't want to just discourage you. But you know, my one of my former attendings used to say, mentors used to say, um, when you grow older, your search pattern, the, the stuff that we look for, becomes longer, and your report gets shorter. So I know it's counterintuitive, but what it means is that you look for a lot more things quickly versus, and the report is completely different thing. And versus when you're older compared to when you are younger. So let's say when you are, sorry, not younger, less experienced. So when you're less experienced, you tend to look for less things. Uh, when you get more experienced, you tend to look for more things. How long? It really depends. So let's say radiograph, like I said, could be very, very tricky. It could be the easiest thing, or it could be the most difficult thing. Uh, so radiograph has all, it depends. Now I can burn the radiograph in like less than a minute. If it's completely negative, because I know my eyes automatically look for those things. Whenever we get a history, let's say, if the history is very specific, then we tend to focus in that area. If the history is, let's say, like foot pain, then I have to spend more time to look for, like, every single toe in the foot radiograph, or the digits, one thing, second thing, third thing, fourth thing, and then generally the alignment. So once you get experience, you can read that less than a minute, one radiograph. As far as CT is concerned, it's depends what kind of CT is it. Let's say CT head. It could be the easiest thing. Again, it's just like a radiograph, because in brain, you cannot do a radiograph, because radiograph would not penetrate the calvarium. Okay, so what you will get is a skull radiograph, and we do not need that, because we need more. We need something that can actually differentiate skull from the brain parenchyma inside. So that's why we need CT in head. Okay, so CT, a head CT would take you 5 minutes. If it's a negative, if it's negative, it might even take you 2 minutes. But that's still pretty fast. But if it is even slightly positive, it might take you like 6-7 minutes. CT of the abdomen and pelvis, which is a workhorse, like chest, abdomen, and pelvis. Chest is relatively simple. But abdomen and pelvis, again, the same concept goes over there. If you have abdominal radiograph, there are only certain things that you're looking for. But if you have a CT of the abdomen and pelvis, there are 1,000 things you can look for in that. And being a radiologist really means that you are an expert in anatomy. So every single thing, has some findings. But again, let's say when you become experienced, even after becoming that experienced, it still takes you minimum 15 minutes, at least 10 minutes to read a CT, abdomen, and pelvis. There's so many things. Now, the other thing is MRI, right? MRI, again, it's very tricky. It's similar to CT, but there are other things that you're looking for in the MRI. MRI of the brain, they have so many sequences, sequences mean they have a lot more, so one is like a T2, one is a fluid signal. There are so many things that you have to combine to make a report. You are in CT, you're only looking at one thing. Or you can just window it and hey, this is a bone window, this is a soft tissue window, and you're looking at that stuff. In MRI, the windows are already given it to you. Just pick at that. Let's say this is a T2 weighted image, this is a T1 weighted image, this is a FLAIR image, which has the everything fluid signal is suppressed. So, MRI would take you a little longer. So let's say MRI of the brain, it might take you 15 minutes. MRI of the knee, even with that much experience, will still take you 15 minutes. MRI of the shoulder, that will even take more, like 20 minutes. MRI of the spine, depending which spine, let's say cervical spine, thoracic, lumbar spine. If you're flying through that fast, you're gonna miss stuff. So that does take longer. So I would say at least like 20 minutes for one of those studies. If you're reading ultrasound, again, ultrasound is a very handy tool. That might take you anywhere between 5 minutes to 20 minutes, depending how crazy the ultrasound is. Let's say body ultrasound, abdomen ultrasound, that might take you 15, 20 minutes. If you have an OB ultrasound, depending how far, like the first semester, trimester, second trimester, different things. If you have a renal ultrasound, depending, it takes 15 minutes to 20 minutes. Yeah. So I would say, ultrasound usually 15 minutes to 20 minutes. Yeah. Hopefully that. The other thing, if you have a nuclear medical scan, again, that's a completely different ball game. It might even take you 5 minutes. It might even take you 15 minutes, depending on your comfort level, because not everyone reads nuclear medical scans. but everybody is trained though. Almost everyone is trained to read that. So let's say if you don't see that stuff regularly, it's gonna take you some time. But if you see it all the time, it might take you like 5 minutes, you know. But it does take 10 to 15 minutes, I will say. And then mammography. Mammography has, again, the highest resolution of anything. So not even the regular monitors could work on it. Not even my 3 megapixel. It needs a 6 megapixel monitor to see that finding. So, the mammographers, they are pretty fast. Usually screening mammogram, they can beat one study every 3 minutes. Yeah. Hopefully that answers your question.
Yes. So you did mention chest x-rays, and in light of COVID-19 at a heightened level 2-3 years ago, what did those x-ray findings look like on patients' chests?
So that's a good question. First of all, it was pretty hard. I was a fellow, finishing up my fellowship when the COVID hit. And so when I went to Dartmouth, it was the height of COVID. Um, Now coming back to your question, uh, the chest radiograph does not have a specific findings for COVID. Um, but when we get the history that the patient is COVID positive, so whatever finding we do see in chest radiograph is mostly related to COVID. On a CT, on the other hand, it has a relatively more specific finding. But the way radiology works, especially for COVID, is that even in CT, those are relatively non-specific findings. So in COVID, let's say, depending how far the stage of the COVID is, let's say if it's an early COVID, you might see hazy opacities, ground glass opacities, But if it's more like when the disease progresses, you will see more consolidative findings. It would be more dense. This is what I mean. Like it would look more bright, more white. On the other hand, it would look a little bit white or like grayish in the beginning, and as it progresses, it becomes more white. Okay, so that means there's more accumulation of the fluid that we are able to see. Okay, does that answer your question? So yeah, we did see a lot of those crazy things, and obviously everyone was getting chest X-rays, CTs, CT chest X-rays. Was a lot of them, and you have other findings of COVID too. Let's say we were seeing neurological findings in COVID. It's crazy to think, but it can affect anything, And again, those are very non-specific findings, Yeah.
For sure. A question from our Zoom chat about residency for radiology. What is the average length of residency after med school for radiology?
Yeah. So basically, residency is essentially total 5 years. Let's say first year is internship. You can do which we call a prelim year. You can do it in you can do prelim in medicine. You can do prelim in surgery. You can do a transitional year. Vast majority of the people, they do medicine or they do surgery. Let's say if you want to go to procedure-based radiology, which is intervention radiology, you tend to go towards surgical, prelim in surgery. But that's not there's no such rule. I'm just saying what people tend to do.
Mm-hmm.
Because people always change. I've seen a lot of people, they change their, they want to do something else and then they did something else. Yes, but it's essentially 4 years. So 1 year of internship, 4 years of residency. But nowadays, almost, you still have quite a few general radiologists which are not fellowship trained, but those are very old school guys, and they tend to be old school guys who are very, very experienced, so they don't even need any fellowship, to be honest. But nowadays, almost everyone does fellowship. So fellowship is again 1 to 2 years, depending what kind of fellowship it is. And one field is very different than the other field. Believe it or not, I'm talking about radiology, and I can tell you, like I was giving you example earlier, one image is completely different than the other image. It's you could be doing neuroradiology, you could be doing mammography. Mammography is its own beast, you know, uh, or you could be doing intervention radiology, and now that is completely different. So, it's very heavily procedure based. Or you could be like me, doing a musculoskeletal radiologist, but I more likely function as a general radiologist, which is where majority of the radiology is. The difference between general radiology versus general medicine, and it's all its subspecialties, is that, let's say, the difference between cardiology and pulmonology is a lot more, right? Or rheumatology is a lot more than in radiology. Radiology, everything is more closely connected. So more people tend to be general radiologists, and then there's a small area that they feel super comfortable with, or they have done fellowship in, then they basically make it as their specialty. Does that answer your question?
Yes.
Okay.
You also mentioned how we should be staying up to date on our research. Are you participating in any ongoing clinical research projects right now?
Yes, I am. Not heavily, very heavily, but I am. So let's say one of my papers when I was a fellow got published by one of the reputed papers. Um, we were just looking for one of the bone tumors to see if you need any. It's not really a bone tumor, but it's a precursor to bone tumor, if that makes any sense. It's called enchondroma, and we were looking for if you need any radiographical follow-up on those patients. What we found was that you don't. In enchondroma, you don't need anything unless you have increasing pain over there, or something is different. Then you get a follow-up by orthopedic oncologist. That was one of my papers. Then the other papers was that we are looking for uh, basically functional capability in a patient who has rotator cuff. Rotator cuff means like shoulder, intrinsic muscle of the shoulder, fatty infiltration. To see, basically, fatty infiltration essentially means that if when you get older, you basically lose the functionality of a lot of your muscles in the shoulder. They become weak. Okay, weak, as well as uh, sometimes if you have an injury, you can lose functionality over there. So we looked into that, and I think there were like 3 or 4 papers just based on that. We are looking for different things. So yeah, the point is that if I'm doing some research, yes. So research is also an exciting part of radiology. You can be doing, yeah, there are a lot of research opportunities in radiology.
Can you please go over the different types of imaging views that are predominantly used in radiology?
Absolutely. So let me just get back to my slides. Okay, so let's say this, right? So this is called AP pelvis. Okay, so there could be a different view, which would be called like inlet and outlet view. So you see this. This is called in outlet view. You will have this thing. You're looking into it. So which is this pelvis would look like a ring. Okay, so then there's an outlet view. I wish I had pictures. I will show you. And it will be like, you're looking from this hole from here. And then let's say this is the radiograph. This is the right hip. So you could have a dedicated view of the right hip. You could have a oblique view, and you can have the sagittal view. Basically, you're looking on a side. This is the MRI of the foot. This is what we're looking the frontal. Like this is called coronal image. This is a coronal T2. But you can have a coronal T1, or you can have axials. Basically, what you do is you basically are looking at the image like like orthogonally. Basically, orthogonal means like you're looking at it 90 degrees. So that would be different. Then you can have another view. Basically, I could be looking at from the side. So let's say I would be looking sagittally, in a sagittal plane. That would be one view. This is the pelvis MRI. Water-based sequence, I think, is T2, and you could be doing that. Or this is basically a cut through the pelvis, like perpendicular cut. If you're lying flat, you could be doing that, or you could have a coronal cut. What it means is that it's gonna look something like that, or you could have a sagittal cut, similar, from the side. This
Okay.
is, yeah.
Oh, sorry. No, you can keep going.
Sure. Okay. Similarly, this is the cuts. This is called sagittal cut. You're looking everything on the side. Basically, if you cut your body, in a sagittal section, this is how it's going to look like. So this is the workhorse in spine imaging. This is the brain, obviously. CT, MRI, T1, T2 flare of the head. This is the CT of the head. This is just a cut into in axial plane. You could have it in coronal. You could have this in coronal. You could have both in sagittal. This is again similar to what we saw earlier. This is the heart. So this is the longitudinal section. This is the short section, and this is the axial section. So again, they are completely different views. This is the regular CC view from the side. This is the MLO. So this kind of like an oblique view of female breast. This is the thyroid gland. So it's just an uptake gland, and this is a AP view. This is slightly oblique. Okay, ultrasound is its own beast. It can have a lot of views. It's crazy how many views can ultrasound have. This is the longitudinal view. It says sagittal. Basically you're cutting the kidney into half and looking at it. So this is like this is all over the place. So it's essentially similar to this, cutting into half. And then yeah, so quite a lot of views. Hopefully that answers your question.
Yes, it does. What is the typical expected turnaround time for traumatic patients imaging?
Yeah, that's a very good question.
Mm-hmm.
So depends. Let's say normally 1 hour. If it's a stroke patient, they have to act on it relatively quickly. Now that acting time has increased to 4.5 hours, but as far as I'm concerned, they want the findings within 20 minutes or maximum half an hour. So let's say in half an hour, I have to tell them. Otherwise, the interventionists, which are mostly interventional radiologists, they have to act upon it. Let's say they have to do a procedure called Mercer procedure, which is basically they retrieve the clot. They put a catheter through your groin and go all the way up to your brain and back the clot in simple terms. So they have to act on it. either they can do that, or they could just give the TPA, which is basically anticoagulation, through arterial, through venous system, mostly venous system. But if it's like very late, then they do through arterial system. Those studies require us to be, give the report within 20 minutes. A regular study, let's say a regular trauma study where the patient got stabbed in the abdomen, normally 1 hour. But we try to give the report even less than that. So let's say I would give them like 40 minutes, depending how does my list look like. But usually 1 hour is the optimal time, more or less.
Okay, and for our last question, what are some examples of traumatic injuries that POCUS can help diagnose faster than other modalities?
Okay. So let me get your question straight. So could you just repeat the question? Did you ask if any single modality has any benefits over the other modalities? Is that what the question?
Yes, basically,
okay, yeah. Oh, absolutely. So let's say you're looking at a perfect example. So on a stroke patient, the reason we do not do routinely MRI is that it takes time. Okay. So let's say in MRI, by the way, the table time is the key. Like how long it takes for the patient to get the MRI scanned. Every sequence could be anywhere between 1 to 2 minutes to 5 minutes. Okay, so that's a lot of sequences. So let's say your table time could be 30, 40, 50, 30 to 35 minutes. Okay, so doing a regular MRI on a stroke patient would take you, with all the sequences, it will at least take you 30 minutes, which is a lot. You cannot waste that time. Plus, that and not every single place has an MRI or available. Let's say MRI is many community places, it's not available at night, right? At the bigger university hospital is always available, the tertiary center, So that would still take 30 minutes. On the other hand, CT will take you, if you are ready to go, will take you seconds to get the same study. So I could be making the same diagnosis on a CT head, which would take me, like literally 40 seconds to scan, or maybe even less than that. Like it's 20 seconds once you're there. On the other hand, I can make a diagnosis of bleed, right? On the other hand, if you do that on the MRI, it will take you 30 minutes. But there's a lot of caveats to that. Because the thing is, reading a stroke study with a CTA head and neck, which is basically CTA means the contrast is within the artery, so you can make out where the contrast is going, and you can evaluate vasculature. Okay, that's the workhorse of a stroke protocol. That would take you at least 2-3 minutes to do. But finding stroke on that, I can find clot on that easily, but MRI, on a CT, which would take me, at least 15 minutes to read, 2 minutes to, them to do the study, or even 10 minutes for me to read, depending how bad the study is. On the other hand, MRI, if the MRI is ready for me to look at, it will just take me seconds to find out what is exactly going on. So let's say, even though it takes 20 minutes for that sequence, for the whole MRI to complete, 20 to 30 minutes, it will take me seconds to figure out this is what's going on with the patient. That's a stroke area. On the CT, it will take me 10 minutes to figure out. So again, it depends. How long? This is one of the classic examples. Doing a CT, it's very quick. If it's a bleed, on a CT, it's very quick. On the MRI, it will take you little time for them to do the study. To look at the study will take you seconds, because the work is already done for you. So all you have to do is just know how everything looks like on the MRI, and that's it. So it would take me seconds to figure out. But since it takes so long to do, we don't routinely do MRI. Okay, so that's like one example.
Thank you. Thank you very much, Dr. Ahmed. Those are all the questions we had for today. We would like everyone to give a warm thank you to Dr. Ahmed in the chat box for his informative session. Again, thank you so much.
I appreciate it. Thank you. Thanks for having me.
Of course. Now we're going to conduct our closing session with our quiz and future session dates.
I can leave?
Yes, you can.
Okay, sorry about that. Yeah, I just wanted to make sure.
No, thank you so much, Doctor. So the link to the quiz is now posted. So quiz now posted. For our upcoming next sessions, in August, it is Rheumatology Month. So all of the following teleshadowing sessions in the month of August will be centered around rheumatology. Thank you so much for joining, and we'll see you next time.